I think this framework sums up an awful lot of things. The need to link our improvement, not just to look end to end, which I think is difficult, necessary, and important. The need to have a really profound discussion to define the unit of analysis here. And I think there is still quite a lot of debate to be had whether it's a clinical pathway or a patient journey. And we need to debate that and discuss that in the future. I think it's not just a question about using an A3 and a framework and the PDCA scientific method for solving a problem either. I think it's also a question of linking the method to solving a problem. And not just in healthcare, but everywhere. At the top of an organization, one of the most difficult things to do is to actually, out of the very complex set of problems an organization faces, to actually drill down and understand and define those vital few. So I think really defining the few things that would make the biggest difference, both to quality, to delivery, and to cost, and also to staff morale, etc., and to patient experiences, all of those things. That's actually the hardest thing to do, and actually is the place where we need to start. So I think this hopefully the exercise we've done in trying to distill and create a common framework, not a common set of answers, a common framework for thinking about lean and translating lean into healthcare language and being able to tell all of the potential story of lean in healthcare without having to... The fact that it's not just about the right actions taken in the right place, but it's also paying attention to the context, both the national context that incentivizes the wrong behavior, the hospital context that incentivizes behavior that doesn't actually support the value stream. Whatever we're talking about, we need to change the context so that we're actually driving people and giving people the opportunity to do the right things rather than do the things that would be locally their optimum. I believe quite strongly that the budget cuts are going to be more severe than we think. And I think lean is a different answer to those budget cuts. I don't think we have to, and I think it would be a real danger to resort to the political lobbying game by trying to scare the politicians that we're going to cut services, because they're going to respond by, well, we're going to cut your pay. And they've already mooted that in the press. So I don't think that's an answer and a very clever strategy, because every other public sector is facing the same kind of issues. What we have to do is actually find a way, a better way to work together, which is actually what lean is all about. A better way to work together to deliver more and better care for less resources. So that, I think, is at the bottom line. By extension, I agree we don't have yet a lean hospital. And it's still a journey towards really being able to see what a lean hospital looks like. And I can see the big pathways now. I think we can see the core patient pathways through the hospital, the ones that are admitted. We can sort of see the patient pathways in and out of the hospitals, the day cases. We can see the support flows, and we've talked about synchronizing the support flows. We haven't talked much at this conference about the procurement, although we have mentioned a little bit, the procurement and deliveries of supplies processes, which I think have tremendous potential. And there, you know, this is not rocket science. This has been done. We did this in the grocery industry many years ago. I think there's a 30 or 40% potential saving in the procurement budget to be had if we manage that whole process correctly. And I think there's great potential to release management's time by redesigning the management processes. If we could do those, I have in my head a vision of being able to actually sketch out the core processes of a hospital on one sheet. It's going to be hard to do, but I'm determined at some point that's what we need to do to be able to envision what a lean hospital looks like as a collection of processes. There's a lean hospital as a collection of expertise and departments, absolutely, but there's a lean hospital also as a collection of processes. And I think we will get there with a bit more research. I think David makes a very, very good point that not only should we be thinking about the upstream and downstream pieces of the healthcare system, but actually we should be thinking the next step, which is actually redesigning the system from scratch, and possibly questioning even the existence of the current hospital in the current configuration in the future. I think there are many ways of delivering care. There's never one best way for all kinds of patients, for all kinds of situations. And so there is no one best way, I think, is vital. And I think getting the different services, which are now all taking up lean really quite fast, together, that's a real possibility that wasn't there 6 months ago. And there's great, great potential for doing that. And there's another area that we haven't talked about. We've done some work in the past on the supply chains and the whole testing process in pharma, but also supply chains of all of the stuff that is made and supplied to hospitals. And the potential saving there is absolutely staggering. I mean, it's a 2-year pipeline to make a drug. I've said this before, and I mapped it, I've walked it, and that could be a 30-day pipeline from the initial ingredient manufacture to the point of use. The savings are huge, but they will not be released unless the government has a very different discussion with the industry about how to share the gains. At the moment, all the incentives are for them not to do anything about this. So changing the context there, I think, could release a staggering amount of money. And again, it's not rocket science. All of those issues have been piloted in other sectors that have achieved the kind of reduction in supply chain from 2 years down to 20 days. It's being done regularly by many other industries for whom it's absolutely necessary. So I think the potential gains are really very large. We can't quite see them all yet. I think we can begin to see them at a hospital level. I don't think we can see them at a total system level, but that's a task ahead. So now is the time, we kind of know the what. And I think we've developed a method. I think many others have variants of that method, and that's great. But the next step is to really focus much more on the how. And I think there are 2 ways of doing that, and you've had examples of that today. One is absolutely learning from the experiences of the pioneers, extraordinarily important, and important that they systematically and everybody else systematically review what works and what does not, and learn from it. And the second is actually by carrying out the kind of action research that we've been, action learning and action research we've been doing, to learn how to, in the future, make value stream management work, to establish stability across the organization through visual management and operations management, and to develop the experiential learning that's going to be necessary for every level in the organization, not just on the shop floor, that we talked about earlier. Think about the action learning approach versus the pioneer approaches, the kind of a left brain, right brain way of tackling this. These are absolutely complementary insights and routes to discovering and systematizing in a way that allows us to accelerate the progress of Lean. So the challenge, I think, now absolutely is for us over the next year, 18 months, 2 years, to actually address head-on the questions of designing a management system to support Lean in hospitals, because that is the key change. And actually, if you reflect on it, the management of hospitals is changing very, very fast. Very fast from a few years ago, not that long ago, from typical public sector management, which was essentially, as David said, about budget administration, dealing with the headquarters, with firefighting and checking on those budgets. And quite quickly, through the Foundation Hospital Program and Monitor and all the rest of it, putting in the core elements of traditional modern management, of allocating resources, clear lines of authority, all of those things that you've had to do to get foundation status. Now we're saying we need to add another dimension to this, which is the ability to manage those horizontal flows of patients, of support services, supplies, etc., etc. This is a very radical shift over a very short space of time in mental models, in behaviors, and in the way we manage. And that means we have to do a lot more of the work that Ian began to describe, of actually understanding what is the work of management. And how are we possibly going to reduce that huge overburden on every single manager, which is the current management system. I mean, staggering challenges to prioritize work and to allocate work in line with capacity, just as we're trying to do down at the service level. So what is it that managers actually can do? Let us deselect the things that they will never have the time to do. Simply overloading them is not the answer. So I think there's an element there of understanding the work and the time of managers. There's an element about where managers spend their time. John talked about a very large fraction of the time being on the Gemba, and rightly so, doing standard management on the Gemba. That's far from the current practice in most hospitals, where career paths are made by your presence in the firefighting meetings, and not by going to the Gemba. A completely wrong set of incentives. And probably the most difficult sets of skills of all, which policy deployment can help enormously with, but good problem-solving skills of mega problem analysis, which is deselection and prioritization. So there are a bundle of issues there that we need to address, not in the traditional Gemba language of the shop floor. We need to address that in the language of the work that managers need to do, and should be doing in a lean healthcare system. So I think that is the research agenda for the future. How can we change the management system to allow managers to do the right kind of things, and to drive and facilitate and prioritize and incentivize and so on, and lead the right kind of things through the organization? So management is the agenda. Now the agenda, so where do we start? Well, of course, you start where you are. And we start, you go read the book, gather your evidence, focus on your vital few, begin to use this scientific approach in your areas, in your span of control, and where you can work. And then second issue, which again I think we still have some work to do as a movement to be good at, which is actually building a business case for the proposed interventions. We can build a process case and demonstrate the process results. What we're not yet very good at is turning that into money. And yes, it would be good to turn that into safety and morale and infections and quality measures and so on. We need to actually have a methodology for building a business case. And then talking about the business case versus the way hospitals are currently rewarded. Because there are lots of perverse incentives that will actually mean that you could make your hospital worse off at the time by doing the right things. So we can now have a meaningful discussion about, it is clear, the evidence shows that this is what we should be doing, but yet your incentives, whether they're departmental incentives or system-wide incentives, are actually driving the wrong thing, wrong kind of behavior. Then we can have a discussion about changing the incentives. So, building a business case, I think also is not just about building the business case for the ability to turn this into money. It's also understanding the IT needs, which I think are fundamentally different from the traditional IT needs for the business, and building the visual management system and even electronifying that for daily management of processes. So that, I think, is a research task as well. It would be great to continue and expand the sharing of pilots and stories from the pioneers and with others, and particularly, I think, learning what doesn't work. We hear a great deal of things at conferences about the good things that work. It's not so easy in public to talk about the things that really didn't work, and yet actually that's where we learn the most. So I think we need to think about that hard and think about how we can do more of the sharing, which means that we can actually accelerate our journeys. And I think, yes, possibly harness this learning in some kind of networks of some kind or another. I have no particular fixed view about how we might follow and mirror John's networks in the United States. It's clear to me something is required that will help us do this across Europe as well as across the United States. We have to figure out precisely what that is, and I would like to have a dialogue with you electronically over the summer to figure out to define those issues clearly. And find some, the other thing I think we need as we go above the parapet, as I said at the beginning, is that we need to find some really high-profile champions to lead the charge across the UK, not just for healthcare, but across the public sector, and to actually articulate the case for lean, not in the language of lean, not in the language of the healthcare industry, but in the language of the general public. And I don't think we've actually been very good at doing that, and that's, I think, a challenge. So we need to find those champions who carry significant weight in public affairs that are going to do that. John's going to do that in the United States. There are others, Paul O'Neill and so on, who have also taken upon it themselves to pontificate on these matters. I think we need to find those champions, and we need to provide the evidence, and we need to write the stories that will resonate with the general public. So, just to conclude, back to the core questions. This isn't a question anymore, I don't think. I think it is very clear the potential is there, and we kind of know, and there is enough experience to convince us that we could do this. And we know the actions that work, we know how to link them together, and we know the potential results. And I think we will, over a short period of time, begin to build quite rapidly the experience of making the theory of value stream management work actually a reality. And the question, of course, ends up is, can you lead lean in your hospital? It's not about can we do lean, it's can you lead it? And if not who? Who? But there is a second question, and I think that's an equally important question, is what can be done within the hospital, within the country, within Europe, what can be done to help you lead lean in your hospitals? So I'd like to end that there. I hope that you found this day useful. I think it marks another step in the evolution, the maturation, if you like, of the lean healthcare movement. The Global Lean Healthcare Summit 2 years ago was definitely a staggering leap forward in bringing people together for the first time, and the pioneers for the first time. And this, I think, marks another step forward, and I hope the book that we've published will help you understand everything we've been talking about today,